changes in the recent ASRA guidelines for regional and pain interventions, and what are the differences between the guidelines for regional and CZ and pain guidelines, and newer oral anticoagulants. Then we'll discuss about the CHAT scoring system, and in the summary, we'll discuss what are the similarities and differences between the pain and regional and CZ guidelines. Now, regional and pain interventions are practiced increasing because of a better patient outcome and satisfaction result. And we can see that nowadays with increasing comorbidities, anticoagulants, antiplatelets, and thrombolytics medications are more used because of CV and CAD incidents. What is the problem basically? Even if a patient is non-coagulated, then the spinal incidence of spinal hematoma is 1,50,000, and in epidural with the spinal hematoma is 1:220,000. And if patient is on anticoagulants, then this incidence increases. For spinal, it will be 1:1 lakh, and for epidural, it is 33:1 lakh. And we should not only focus on the prevention of the hematoma, definitely it is our focus, but if it ever happens, then we should also know how to treat and how to detect and treat this patient. And there are the certain literatures, there are certain reports in the past also, like spinal epidural hematoma after patient treated with clopidogrel and enoxaparin. There is another report with the extensive retroperitoneal hematoma after lumbar plexus block, and patient was laterally anticoagulated after the block. And enoxaparin associated SWAS hematoma and lumbar plexopathy after lumbar plexus block in anticoagulated patients. And spinal epidural hematoma following epidural anesthesia in presence of antiplatelet heparin therapy. These are some certain literatures which indicate that we should definitely have some guidelines to safeguard ourselves and the patients. And these are the recent ASRA guidelines in which they introduced about the guidelines for the pain intervention. In 1998, the first consensus conference on neuraxial anesthesia and analgesia was held. In 2002, the second consensus conference was held. And 2010, they released the third edition of guidelines. And it was in 2018 when they thought of introducing the guidelines for pain interventions. And why we need separate guidelines for the pain? Initially, we were already following the regional anesthesia guidelines, but there were certain incidents where they reported some incidents of spinal hematoma, epidural hematoma after patient of a spinal cord stimulator or cervical epidural steroid injections. And even after following the ASRA guidelines for regional anesthesia, and these patients were old age, but coagulation profile was normal. So they thought that the certain high-risk procedures like a spinal cord stimulator, intrathecal pump, or cervical epidural should be considered as a surgery, and we should have separate device guidelines for the pain intervention to save the patients. And they stratify the risk according to the risk procedures, like high-risk procedure, intermediate risk procedure, and the low-risk procedures. In the high-risk procedure, there is spinal cord stimulation trial, dorsal root ganglion stimulation, intrathecal pump, and vertebroplasty and kyphoplasty. Intermediate risk procedures are the interlaminar epidural steroid injection, transfemoral epidural steroid injection, cervical facets, intradiscal procedure, and certain sympathetic blocks like celiac plexus blocks, plantar nerve block, trigeminal and sphenopalatine ganglion block. In the low risk procedures, they put the peripheral nerve blocks, joint injections, trigger point injections, lumbar and thoracic median branch nerve block, and sacroiliac joint. Now, there are certain anticoagulants that we encountered in our practices are the antiplatelet medications, oral anticoagulants, heparin or the low molecular weight heparin, herbal preparations, and newer anticoagulants. Usually, their guidelines are made by from the evidences collected from the past, but mainly these are mainly pharmacological based depending on the drug. And there are one paper they were delivered by and he suggested that the 5 half-life should be taken for discontinuation of the drug, because if we see at the 5th of the discontinuation of the day, there is only 3% drug left in the plasma, so it is almost minimally effective for the coagulation, and we can safely proceed the procedure. And if a patient has a low coagulation risk, then we can easily go for 2 half-life interval. Otherwise, normally we should follow the 5 half-lives for discontinuation of the drug. And if a patient is renally impaired, then we can definitely consider for more life, like 6 or 7 half-lives. And for resumption of the drug, they suggested that 8 hours minus the time for the anticoagulant to reach the peak effects. Rochner et al. Cited a work for Bauma and Moschner, and he cited an example of a cerebral emboli where they said that the thrombolysis is almost ineffective after 8 hours. So they formulate that the clot gets stable after 8 hours. And if we consider for low molecular weight heparin, it gets peak effect at the 4 hour. So for assumption of the low molecular weight, we should consider 8 hours minus 4 hours. That is the 4 hour will be the resumption period for the low molecular weight heparin. Now, why we need thromboprophylaxis? We all know that there are certain conditions where there is chances of venous thromboembolisms are high, where we are already practicing it in our anesthesia practice, like surgery, trauma, immobility, cancer, venous compression, previous history of a thromboembolism, increased age, pregnancy, oral contraceptive pills, erythrocyte stimulating agents, inflammatory bowel disease, myeloproliferative disease, obesity, and central venous catheterization. And we already know that a perioperative mechanism of a patient on the antiplatelet, like we know that if patient is with a bare metal stent, we should wait for 6 weeks. If he is on a drug-eluting stent, we should wait for 6 months. And we should withhold the clopidogrel for 5 days. And if patient is high risk, then we should bridge with the low molecular weight heparin. And there are certain inherent risks. We can divide it into 3 categories. Patient factors, like female will be have a high risk, elderly, abnormalities of spinal cord and vertebral column, and which is the main cause for pain intervention guidelines, because in the pain patients there are already compromised spinal canal there is, so the chances of trauma and bleeding will be more with the pain patients. And in seizure factor like traumatic needle placement, epidural catheter, and definitely the dosing factor. If patient is given epidural and immediately LMAW is started, then the chances of bleeding will be more. So these are the 3 inherent risk factors. Now, certain specific anticoagulant and ASRA recommendations. This is the main topic that we are going to discuss. And these are the antiplatelet medications: aspirin, non-steroidal anti-inflammatory drugs, thienopyridine derivatives. These are platelet ADP antagonist, clopidogrel, ticlopidine, and prasugrel. And platelet glycoprotein GP2B3 receptor antagonist, platelet P2Y12 receptor antagonist, and a phosphodiesterase inhibitor like cilastatin. Now, aspirin, its mechanism of action is cyclooxygenase. It blocks the cyclooxygenase, which is responsible for the production of thromboxane A2, and which promote the platelet aggregation and cause the vasoconstriction. So, aspirin will block the cyclooxygenase, and it helps in prevention of the thromboembolism. Duration is platelet inhibition is 60% platelet are affected, and but 10 to 15% of new platelets are formed and put in the circulation. So after 4 to 5 days of discontinuation of the aspirin, there will be 50 to 60% of new circulating platelet which are unaffected by the aspirin. So we can safely give the our procedure after 4 to 5 days of discontinuation of the aspirin. And long-term use of aspirin may lead to decrease the prothrombin production, which can increase the prothrombin time also. And the NSAIDs, these inhibits the cyclooxygenation by decreasing tissue prostaglandin synthesis. Mainly COX-1, the drugs which affect COX-1 will be the mainly culprit for the bleeding. And its action is reversible, and duration of action is 1 to 3 hours. 1 or 3 days. Sorry, and ASRA recommendation for aspirin and NSAIDs. Either medication alone does not increase the risks. Then there is increased as well concurrent use of other medications, and there are no laboratory tests available. A normal bleeding test does not guarantee the normal homeostasis, and abnormal bleeding time does not necessarily indicate the abnormal homeostasis. In addition to assessment of concomitant medication, there are the following other factors like history of bruising, history of excessive bleeding, female gender, and increased age. Now the guidelines for regional anesthesia, they say that we should continue the aspirin and NSAIDs. For pain guidelines, in a low risk procedure, trigger point injections, peripheral nerve blocks, joint injection, continue aspirin or NSAIDs. And for medium and high risk procedure like epidural steroid injection, vertebroplasty, spinal cord stimulator, we should discontinue aspirin and NSAIDs. And if patient is on primary prophylaxis, we can discontinue the aspirin for 6 days. But if patient is on the therapeutic dose of aspirin, as continued prophylaxis, we should discontinue the aspirin for the 4 days. and a resumption of the aspirin will be after 24 hours. You can also note down these guidelines, but it will be a bit boring lecture. It's only theory. Now the phosphodiesterase inhibitors. Now it is celestazole is PDE3 inhibitor. Its half-life is 10 hours, and dipyridamole is PDE5. Its half-life is 11 hours. For regional anesthesia guidelines, they say we can continue with these drugs. For pain guidelines, to be on safer side, ASRA suggested for discontinue of 5 half-lives, that it will be around 2 days, that is 50 hours. Now this is the chart in which we can clearly say that for primary for prophylaxis, aspirin should be discontinued. If patient is on primary prophylaxis, aspirin should be discontinued for 6 days, and if patient is on secondary prophylaxis, discontinuation period should be for 4 days. For silastazole and dipyridamole, it is 2 days for both primary and secondary prophylaxis, and a resumption period for both are 24 hours. In for regional guidelines, regional anesthesia guidelines, we can continue with this with antitons. For the sets, usually the sets which we usually practice in our routine practice, half-life period is 1 to 4 hours. So discontinuation period will be around 1 to 2 days. Except the pyroxicam, which has long half-life, it is 45 to 50 hours. So discontinuation period will be 10 days. And the resumption should be after 24 hours. In regional anesthesia guidelines, we can continue with the NSAIDs. Now the thienopyridine derivatives, these are the platelet ADP antagonists and P2Y12 receptor inhibitors. These have an irreversible effect on the platelets. And for regional and pain anesthesia, pain guidelines are the same. They say ticlopidine should be withheld for 10 days, clopidogrel for 5 to 7 days, prasugrel for 7 to 10 days, and should be resumed 24 hours after the procedure. And there are no laboratory tests available for this medication. This is the chart. Clopidogrel and prasugrel are the product. These go for two-step metabolism before forming the active metabolite, which directly act on the P2Y12 receptor. Ticagrelor, which is Berlinta, is directly acting oral drug and act on the P2Y12 receptor. Canagrelor is directly acting IV receptor. Discontinuation period for both is almost same. For clopidogrel, it is 5 to 7 days. Prasugrel 7 to 10 days, and ticagrelor Berlinta should be had for 5 days. And resumption is after 24 hours. For clopidogrel, they have said that if we have to give single dose like 75 milligram, we can restart after 12 hours. But if we have to give the loading dose, that is 300 milligram, we should wait for 24 hours. Now, platelet GP2B3A inhibitors, these are usually out of view from the pain intervention, because if patient is needing these drugs, then pain interventions are out of question. But still, they say that it takes 24 to 48 hours until the normal platelet functions are restored. So non-urexia blockade should be taken until platelet function is normal. Now the warfarin, it inhibits the vitamin K formation, so there is depletion of the vitamin K dependent protein, that is prothrombin and factors 7, 9, 10 and 2. And duration of action is onset is 8 to 12 hours with the peak at 36 to 72 hours. Now, the other perioperative management of warfarin that we are already following, discontinue it for 5 days and assess the INR. And if patient still INR is more than 1.5, we used to give the vitamin K injections. And if patient has a high risk of thromboembolism, we used to bridge it with the low molecular weight heparin. And warfarin prolongs the PT-INR. And for in case of warfarin, there are the two scenarios. If patient is not on warfarin, then and the patient's INR is less than or around the 1.4, then it is accepted for the neurexal blocks, because clotting factor activity will be above the 60%. But if patient is on warfarin, then a regional and pain guideline will be same. We should discontinue warfarin for 5 days, and a resume of the warfarin should be after 6 hours. ASRA guidelines says that we should accept a normal INR as less than 1.2, but European guidelines say that INR can be 1.4 can also be accepted. But we should usually follow the ASRA guidelines, but it is clear from a paper by Dr. Benjamin, and they have measured the clotting factor concentration after 5 days discontinuation of the warfarin at various INR level. And they studied 120 patients. In 20 patients, At the INR less than 1.2, they said that all the clotting factors were above 40%. And in INR range of 1.3 to 1.4, they found that clotting factor 10 were the range of 36% or 20%, and clotting factor 2 were in the range of 46% and 37%. So in the if the INR is more than 1.2, then clotting factor is below the 40%. So bleeding risk will be high. So we should usually follow the ASRA guidelines for normal INR considering it at 1.2. Patient receiving post-operative epidural analgesia and warfarin should have normal should have daily PT-INR monitoring, and we should monitor the motor and sensory component. If INR is more than 3, we should withhold the warfarin, and if epidural catheter should be removed only if INR is less than 1.2. If anyhow epidural catheter is removed at the INR of 1.4, we should monitor for neurological deficit for 24 hours. Now the heparin, the mechanism of action is it binds with antithrombin 3 and neutralizing the activating factor of 9, 10, 11, and 12. The elimination half-life of IV heparin is around 56 minutes. Now the ASRA recommendation for heparins are for IV heparin, regional and pain guidelines are the same. Heparin biological half-life is around 60 minutes, and half-life is dose dependent. If it is low dose, that is 25 units per kg, then the half-life will be 30 minutes, and the 5 half-lives will be around 2 hours. If the half-life, if the heparin dose is 100 units per kg, we are considering patient weight to be 70 kg, then the half-life will be 60 minutes, and 5 half-lives will be 6 hours. And the high dose, that is 400 units per kg, it will be very high dose, 28,000 to 30,000 units, which are usually not normal for in the routine practice. It is usually used in the cardiac anesthesia, so pain interventions are after in this high dose. IV heparin should be discontinued before neuraxial block, and the time should be around 6 hours, and a resumption after the neuraxial block should be 1 to 2 hours. If we are using the subcutaneous heparin in the BD dose, in the regional anesthesia guideline, if a dose is less than 10,000 units per day, then discontinuation period should be around 4 to 6 hours. If dose is between 10,000 to 20,000, then discontinuation period should be 12 hours. And if dose is more than 20,000, then discontinuation period should be 20 hours. So we can consider that a discontinuation period for regional anesthesia is 6 hours, 12 hours, and 24 hours. And for regional anesthesia, after regional anesthesia, we can resume the heparin after 1 hour. And pain guidelines say that we should avoid this scenario if possible. But if anyhow we have to proceed with this dose, then this discontinuation period for the low risk procedure should be 6 hours, and for the high risk procedure it should be 24 hours. And the resumption of the subcutaneous heparin should be for low risk procedure it is 2 hours, and for high risk procedure it is 24 hours. In a regional anesthesia, resumption is 1 hour, and for pain guidelines, resumption for low risk is 2 hours. If patient is on a TID dose, initially the regional and pain guidelines were not recommending a TID dose, but now recently some literature has come up which have clearly said that epidural can be safely given even if patient is on TID dose. And regional guidelines say we can proceed with this dose. Discontinuation period should be 4 to 6 hours, and resumption should be after 1 hour. Pain guidelines same say that we should avoid if possible, but we may proceed with the following guidelines. In medium risk procedures like epidural steroid injection or a cervical facet block, the discontinuation period should be 6 hours, and for high risk procedure like vertebroplasty and spinal cord stimulation, the discontinuation period should be 24 hours. And the resumption period is same like for medium risk 2 hours, and for high risk it is 6 hours. Mini-dose subcutaneous heparin does not contraindicate a neuraxial block, like if we are giving it for prophylaxis. Patients should be screened for concurrent medication that may impact. We should always take care that what other medication patient is taking, which can also affect or have additional effect for the coagulation. The prophylaxis for 500 units subcutaneous twice daily dose is not contraindication. And if a patient is taking higher dose, then we should enhance the neurological monitoring. If patient is taking heparin for more than 4 days, then we should always take the platelet count because there can be a heparin-induced thrombocytopenia. So always get the fresh platelet before proceeding for any pain interventions if patient is on heparin. Now the low molecular weight heparin that we are regularly using for DVT prophylaxis is enoxaparin, deltaparin, tizaparin. Factor associated with hematoma formation with enoxaparin are the female genders, elderly, if needle is traumatically placed, multiple needle attempt, catheter placement, and indwelling catheter if we are while giving the LMWH administration. Continued epidural administration and LMWH increases the risk of hematoma formation to 1 is to 3000, and for spinal anesthesia ratio is 1 is to 40,000. If we are giving a low molecular weight heparin and constantly administer the epidural of spinal anesthesia, the risk will be very high. It affects the factor 10. Low molecular weight heparin does not alter the patient's PTT, and there are no laboratory tests available for measuring its action. ASRA recommendation for low molecular weight heparin. Regional and pain guidelines are the same. If we are giving prophylactic dose of low molecular weight, then the discontinuation period should be 12 hours. And if we are giving therapeutic dose, that is usually mainly BD dose, phenoxaparin, then the discontinuation period should be 24 hours. For deltaparin, discontinuation period should be 24 hours. And the resumption of the catheter removal after low molecular weight heparin is 4 hours. And it is FDA approved type. Low molecular weight heparin should be held for 12 hours prior to neuraxial blockade for normal dosing that we are using for a prophylactic dose. And if we are administering the following dose like enoxaparin in 1 milligram per kg for every 12 hours or 1.5 milligram per kg every 24 hours, then the discontinuation period should be 24 hours. And same is for deltaparin, 120 unit per kg every 12 hours or 200 unit per kg every 24 hours, and for tizaparin doses 175 unit per kg every 24 hours, then we should have the low molecular weight heparin for 24 hours. Now fibrinolytic medication or thrombolysis, usually these are administered in the patient or MI, so scenario should be avoided. But anyhow, if we have to give the start with any pain intervention, then the regional and pain guidelines say that we can wait for 48 hours. The newer anticoagulants, fondaparin X, it is medication used for the DVT prophylaxis. It binds with antithrombin 3, which neutralizes the factor 10. And peak effect in 3 hours with half-life of 17 to 21 hours. It has irreversible effect on platelets and need further experience to formulate the guidelines. Regional guidelines say it is not recommended, but recent pain guidelines have come up with a 5 half-life. That is, we should wait for 4 days before proceeding for any procedure. And it has black box warning, same as low molecular weight heparin. Now there are certain other new anticoagulants that are used in interventional cardiology. These are the bromelain and lepidolin, and these are not recommended as we have no clinical experience with these drugs. Now the novel oral anticoagulant agents. All new anticoagulant agents are either factor 10 inhibitor or thrombin inhibitor. Factor 10 is the junction of a intrinsic pathway and extrinsic pathway. Drugs are the dabigatran, rivaroxaban, apixaban, and edoxaban. The regional and pain guidelines are the same for NOVAX, and they say that if patient is very high risk for myocardial infarction or chances of arrhythmias are very high, we can discontinue for only 2 half-lives and can proceed with a low-risk pain procedure like a trigger point injection or peripheral joint injections. But if a patient is not very high risk for MI or arrhythmia and pain intervention is an intermediate or high risk procedure, so like cervical epidural or a spinal cord stimulator, then we should wait for 5 half-lives. Now, see the chart, they say that a dabigatran, it is metabolized 80% through renal, rivaroxaban is 33% renal, apixaban metabolized through renal, edoxaban and betrixaban is metabolized through renal. And regional and pain guidelines are almost same. They say that the discontinuation period should be for 3 days for most of the drugs, except in case of dabigatran, if there is renal impairment, then the discontinuation period should be for a renal patient will be 5 to 6 days more. And there's a pain guideline 4 days and 6 days for the renal. Otherwise, it is discontinuation period for every drug is 3 days. That is 72 hours. discontinuation and resumption for dabigatran 3 days or 5 days, 5 days for the renal patient. And the resumption for the low risk procedure is 6 hours, and for high risk procedure it is 24 hours for all the drugs. But if patient is very high risk for the venous thromboembolism, we can start the drug 12 hours after the procedure. It is almost discontinuation period is 3 days for all the drugs. Now, there is reversal of the NOVAX are also available, like adalimumab and andexanet alpha. Adalimumab is a monoclonal antibody fragment. It binds with the free and thrombin-bound dabigatran, so it reverses the dabigatran approved by the FDA, and it normalizes the elevated occurring clotting time in dabigatran patients. 90% of the patients. Effect is within the minute, and dose is 5 gram IV. So 250 ml infusion or 2.5 grams are given for reversal of the dabigatran. And for the reversal of apixaban and rivaroxaban, it is andexanet alpha. It is recombinant human protein and binds and sequestrates factor 10 inhibitor within the vascular space. For apixaban, the anti-effector 10 activity reduced by 95%. And for rivaroxaban, the anti-factor 10A activity reduced by the 92%. So the effect of these drugs are reversed. Now, this is a new thing for most of us, like antidepressant in renal anesthesia or anesthesia. We were used to suggest the patient that you should continue your antidepressant medication. But for pain medication that we are regularly using, SSRI, we should withhold these drugs for minimum 5 weeks, because these mainly antidepressant SSRI are affect the platelet aggregation, so these should be withheld. Regional anesthesia guidelines say we can continue, but pain guidelines say we should discontinue it for 1 to 2 weeks, except for fluoxetine. Discontinuation period for fluoxetine is 5 weeks, because it has a active metabolite norfluoxetine, which has half-life of 17 to 15 days. And in case of high risk patient for depression who have suicidal tendency, if we have to hold the SSRI, then we should shift the patient to other antidepressant like tricyclic antidepressant for the discontinuation period to safeguard the patients. Now, herbal preparations. About 1/3 to 1/4 of the patient globally are taking a herbal preparation for their health issues. And these are preparation mainly includes garlic, ginger, and these inhibit the platelet aggregation. Ginseng has an anti-platelet component. Alfalfa, chamomile, horse chestnuts, these contain the coumadin component. Vitamin E also reduces the platelet thromboxane production, and ginkgo biloba inhibits the platelet activating factor. Regional guidelines say that we can continue with the herbal preparations, but there is one case report where they noted the spinal hematoma and patient was taking 2000 milligram garlic per day. And pain guidelines say for medium and high risk garlic, if patient is taking garlic 1000 milligram per day, then this should be discontinued for 7 days. And if patient is taking ginkgo biloba, we should check the platelet. But if patient is taking any herbal medication, we should check for the bleeding tendency, and we should check the lab parameters, especially platelets and the coagulation profile, because most of this herbal preparation affects the coagulation profile. And we have noticed in the corona period, COVID period also, because patients are taking the garlic and many patients, and then they come with the increased on the PTI. These are unknown risk. Patient advised for stop of 5 to 7 days prior to surgery. And we should also take care that if a patient is taking any other medication for coagulation. And we should assess the patient for the bleeding tendencies. And I would recommend for all the pain fellows to follow the CHEST score to safeguard themselves for medical legal purpose. And in CHEST scoring, they have given 1 point each to CHF, hypertension if age is more than 75 years, and patient is diabetic mellitus. And 2 points for if patient is having a previous history of stroke or transient ischemic attack. And they noted that there is an increase in the stroke rate. If score is 2, then the increase in stroke rate is by the factor of 4, and if score is 3, then the stroke rate is more by factor of 6. So if patient is having score of 3, then patient will be very high risk if we stop the anticoagulant. So we should discuss these cases, these things, risk and pro and cons with the patient and his relatives. And in high-risk patient, we should think for the low molecular weight heparin bridge therapy during the discontinuation period of anticoagulants. Now, this is the main slide, the take-home message. Uh, this is all the crux of the previous lecture. Uh, for aspirin, regional guidelines say we can continue, and for pain guidelines, they say we should discontinue for 4 to 6 days, and the resumption of the aspirin should be 24 hours. For NSAIDs, regional guidelines say we should continue. For pain guidelines, they say 5 half-lives, that is almost 1 to 2 days, and the resumption of the NSAID should be after 24 hours. Clopidogrel, they have the same for regional and pain and SIA guidelines, that is 5 to 7 days. For prasugrel, 7 days for both the guidelines, and ticagrelor, 7 days for both guidelines. And the resumption in a clopidogrel, we can immediately resume the clopidogrel because it takes around 2 to 3 days for a peak effect. But if we have to give the loading dose for after regional anesthesia, then we should wait for the 6 hours. And in the pain guidelines, they clearly has mentioned that we should wait for 12 to 24 hours. 12 hours we have to give a single dose, and 24 hours we have to give the loading dose, that is a 300 milligram. And for prasugrel and ticagrelor, we should wait for 24 hours. For warfarin, discontinuation period, it should be 5 days or INR should be less than 1.5, and for pain guideline it is the same. And assumption period is 6 hours, pain also same. IV heparin for regional anesthesia, we have 4 to 6 hours, and for pain guideline, it is 6 hours. And the resumption of the IV heparin, regional say 1 hour, and pain for 2 to 24 hours. In all the heparin regional anesthesia guideline, resumption is 1 hour, and for pain guideline, it will be 2 to 24 hours. 2 will be for low risk procedures like joint injection, trigger point injection, and 24 hours for the high risk procedure like spinal cord stimulator, cervical epidural, vertebroplasty. For enoxaparin, the regional guidelines say discontinuation for 12 hours, and pain also 12 hours. Enoxaparin pain and regional guidelines are almost same, that is 12 hours, and pain for therapeutic dose it is 24 hours. Fibrinolytic agent से patient fibrinolytic agent, then we should withhold the drug for 48 hours, and we can resume the fibrinolytic agent only in emergency situations. For NOACs, dabigatran, the guidelines are same for a regional and pain guideline. For 3 to 5 days discontinuation, and 5 days for renal patient because it has a decreased clearance. Resumption is same for both 6 hours and 24 hours. And for apixaban and rivaroxaban, discontinuation period is 3 days. And this is the checklist for procedural anticoagulation management. If any patient comes with anticoagulation, we should have this checklist available with us, and we can baseline patient-specific risk factor for a history, physical examination, and any family history of the bleeding disorder. Physical examination like easy bruising history, brachymucal and renal disease or hepatic disease. Where the patient is on aspirin or NSAIDs and any concomitant medications. If patient is on primary prophylaxis of heparin or the secondary prophylaxis, and especially the anatomical location of the procedure, whether we are proceeding for the cervical, thoracic, or lumbar reason, and risk stratification like high risk procedure, intermediate risk procedure, and low risk procedure. From this checklist, we can chart our care guidelines, like whether to proceed or should wait for some days. Now, if after following all these guidelines, if ever epidural hematoma occurs, then we should also know that how to diagnose and treat these patients. And signs and symptoms of the epidural hematoma are low back pain. Pain will be sharp and it will be radiating to the legs. There will be sensory and motor loss, numbness and tingling, motor weakness, even after the block is ablated, and bowel and bladder dysfunction and paralysis. Diagnostic testing, MRI is the preferred choice. CT scan sometimes, but it can miss the small hematomas and myelograms. And treatment outcome will be if patient is treated within 8 to 12 hours of the onset of symptom, there will be chances of a reversal of the neurological symptom. And emergency decompressive laminectomy with the hematoma evacuation should be done. Outcome is generally poor if we give the treatment very late, like 8 to 12 hours is the window period for this patients. And what are the factors that affects the recovery of this patient? That is the size and location of the hematoma, speed of hematoma development, and severity and the nature of pre-existing neurological problems. And the anticoagulation and peripheral nerve blocks. Case reports have been with the major bleeding with the Schwartz compartment and lumbar synthetic blocks. Patient with neurological deficits had complete recovery in 6 to 12 months. The key to reversal of this neurological after peripheral nerve blocks was that because it was an expandable tissue, and as opposed to the non-expandable tissue in the spinal cord. And reports of complication with axillary infraclavicular supraclavicular have also been reported, but they are very few. And with ultrasound guided blocks, especially in trained hands, risk is very high. This is the normal risk from low to the high risk procedure wise, like local infiltration and then increase with the superficial blocks and deep blocks and epidural spinal procedure will be very high. Thank you. Any question?
So that was a quite a good talk actually. Now a couple of things